That helps me. Because that's another reason I can give that now the money's not even there. So how can states move forward if the money's not even there? And actually some states, even that have expanded, have had a provision. Now we're not sure the federal government's approved this, the CMS as I mentioned, but they've had an opt-out provision that if the money's not there, they do not have to expand. But I've not seen any documentation to say that the federal government agrees to that. That's the other concern I have, is that if you do expand, the way Medicaid has worked in the past, once you enroll people, you've got to pay for them. There isn't any option. And Virginia has one of the most conservative Medicaid systems in the country. So, but that's a good question, and that's one of the things I neglected to mention. But if they do defund or don't appropriate the dollars to move that the ACA forward, that helps and strengthens my position, and I think the position of those of us that oppose expansion. The latest figure I had, because 2013 we don't get that until the end of the year. We do what they call a kind of a re-benchmarking at the end of the year. We do it for public education, do it for state programs like Medicaid and Medicare that we have to be involved in. But we've made payments as of 2012, and it cost the $7 billion that I mentioned. It's 996,835 recipients, almost 1 million people.
Are on Medicaid.
Are on Medicaid. Yep.
What are the qualifiers for Medicaid?
That's a good question. The qualifiers for the current population for Medicaid is what they call aged, blind, or disabled. And these are all federal definitions. So that's just a broad category. Children, a member of a family with children. It's usually single women. The vast majority of the recipients are single women. Pregnant women and certain Medicare beneficiaries. And that is, they've got, again, special designations that, and what it means is it's that dual eligible folks, so they can get Medicare, but then they can also get Medicaid. And that's what we're trying to deal with.
And this expansion, what other groups would be inclusive in that?
What the expansion will do is it'll cover that the biggest single group will be all adults under which would be and the law says 133 of the federal poverty rate, and that's basically an income level to be very simple. We're basing it on 138 because most states are doing that because that's a truer actual reflection, and it's allowed under the law. You say, well, why would you use a higher percentage? It actually helps us, and that's why states use that, but it's allowed under the law. But it's mainly going to be adults that basically are at a certain income level. And I mentioned before, the safety net we're funding now are community health centers and then free clinics. We provide a large number of dollars. In fact, just a year ago, we provided an additional $1.3 or $6 million for free clinics, and they were able to leverage that and get about $27 million worth of free medications from the pharmaceutical companies and generics and all those kinds of things. So we already do, I think, a lot for indigent care, or the population, the additional 400,000 that would be eligible. But the vast majority of them are adults. And again, they're not seniors. Some of them may be seniors depending on their circumstance, but most of them are just going to be adults. Again, 27 or older most likely. So. You're asking all the good questions. And again, I just mentioned I spoke to a nurses group last night. One of the issues that's there every year is there's a shortage. And the reason there's a shortage is because of all of us baby boomers. There are going to be more of us that are living longer, and that's the other whole problem with expanding Medicaid or Medicare in general. whether those programs will be there long term, I'm not planning for Social Security or Medicare. Trying not to plan for Medicare, even though I've paid in, just like everybody else for those, because the baby boom population, the way it's going to work is there going to be more of us that are in the system, that are taking the dollars that we paid in, than the young people that are out there that are be paying into the system. So the system's not sustainable from that standpoint. And on top of that, we're going to cause a shortage of healthcare professionals. And that's why actually we're trying to do things to have more nurse practitioners, more physician assistants, because they're going to be the frontline healthcare providers, because there aren't going to be enough doctors. But if you talk to the nursing schools, and I sat with faculty members of the nursing schools at JMU, EMU, and folks that work at Blue Ridge, they don't have enough faculty members to fill the spots that they need to be able to take the students and have the capacity for the students that we know they need to be able to pick up all those people that are going to be in the system. So, Rick, that's the other problem with the whole system, is there are not going to be enough people. I guess we'll all be taking care of each other. So if you want to be a doctor, you might have to get that training, because I don't know where we're going to get the personnel alone just to help the people we're going to have in the system. And that's going to be a big challenge. There are some people that actually, and we don't know how many there are, but we know there's a population based on what the experts tell us, and also we're looking at what other states are doing that have gone ahead and implemented expansion, and they found in other states there's a certain percentage of the population that they have minimal health care coverage, and it could be they've got a part-time job, but the part-time job provides them some high deductible plan where it's major medical, but nothing for preventive care and all this other kind of stuff that most health plans have now. And I was not aware that there were people that would actually qualify that be in that position, but there actually are a population of folks that are in that position, or they could be working full-time, and it could just be their employer doesn't provide them even 50%. They may provide 30%, and they have to use their own paycheck, and but they're still at the poverty level, and it's all based on again these actuarial tables and facts and figures related to income, and it's all projection. I mean, we don't know until you put the program out there and you start enrolling people, but we do know that, as I said, they come out of the woodwork anytime you put a program out like that, because I mean, and I don't blame those folks. I mean, if they're paying 50, a third or almost half of their salary for whatever portion of health care they are, and then trying to make it on that other portion, and they're at the income level, they're automatically going to go. I mean, they want more disposable income. I mean, that's just human nature. So so that's the problem. We've got that population. But the thing is, we also have funded in the past the community health centers and continue to at this point, and the free clinics to try to help those people. So if they can't meet their deductible, or it's not a major issue, but they need to go in and have something else done, that's what those programs are there for. And we've tried to help people be able to do that. A lot of nonprofit organizations also provide funding for people in their communities to be able to help with health care as well. Now, is it perfect? And are they getting everything that everybody else gets? No. Yes, and that's a good point. Y'all are asking all the good things that I forgot to mention, so that's good. That is one of the things that we're looking at very closely. Now, I have to give the Attorney General credit, because he and actually Governor McDonnell before Ken, when he was Attorney General, really have been moving forward to looking at fraud, waste, and abuse in the system currently. And they've really reined in on a lot of the people. Having said that, there's still a lot that could be done related to that. And actually, the General Assembly has been supportive of Ken and Bob to basically move in that direction to try to find those people it's individuals and it's also companies that are defrauding the state. And we've gotten lots of rewards back in dollars that we've recovered from court cases the Attorney General has taken on the individuals and companies and businesses that have done that. Now, the Department of Medical Assistance Services has just been in the last 2 years also ramping up through paperwork, audits, and those types of things to catch people basically milking the system as well, because you can do it intentionally from a criminal standpoint. That's what the Attorney General is going after, but you can also just kind of cook the books too, to basically say, well, this procedure, it says it costs this, so we'll say we did this procedure that actually costs more. So they're going back and really hammering on the procedures, and the vast majority of the people, providers and individuals, are not defrauding or doing that. But there are people that will and do. So we've ramped that up. But that's also part of the reforms we're looking at to see what else we can do to improve that.
This is a little step to the side, but I think the SNAP card should have photos on them.
We had a tough time getting photo ID for voting. But I agree with you. I think, and that's something I think we could easily do.
I have a friend who knows somebody who gets $500 a month, and she'll give the card to this person, and the person will give her $300 in cash. Yep. I've heard that.
In fact, I've heard that suggestion. I'll have to put that on my list of things to look at for the next session, because I think that would make a difference. And now, if you're issuing an ID, it's very easy to put the picture on it and reproduce it and all that kind of stuff. So. The federal government sets a standard, and then states can ask for waivers to control cost and those types of things with the current system, and that's actually what they're accepting on the expanded population too. But we can set, and Virginia early on set a very conservative list of services that are provided under Medicaid, and so we still control that. In fact, there's a list of what specific services are covered. We've had bill after bill after bill and requests for, ever since I've been in the General Assembly, to add things, to expand, to spend more money, state dollars on Medicaid above the 50% that we do. And we've always pushed that back and said, no, we're going to pay 50, they're going to pay 50, and we need to keep the system. Again, the idea behind it originally was it was supposed to be the safety net for those who couldn't access and didn't have access to health care. It wasn't supposed to be the insurance provider for the vast majority of the citizens. That wasn't the intent. So we do have some control.
If Virginia does not accept this additional money,
Right.
is there
A penalty?
is there a threat that they're going to ratchet up or eliminate
Now,
any
they
waivers?
can always do that through the approval process for waivers. I mean, they could do that. I mean, bureaucrats do that now. I mean, EPA, all of them can do that. And it depends on the administration. Some are better than others. I mean, it's just a fact. And that's true. It's been true probably since
Well, I
George
would
Washington
assume you
was
would have
president.
less confidence in the current administration for doing that sort of stuff.
Yeah, we suspect that there may be some quid pro quo.
Okay.
But more importantly, the Supreme Court said they can't take away your existing dollars for Medicaid if you don't accept it. It's up to the state whether to expand or not. And the Supreme Court made that very clear. So, but that's why the federal government's pushing the states so hard right now. I think they're also pushing the states so hard because they know this train wreck is moving, and the more people learn about it, the longer they have to delay, the more problems that the citizens encounter, whether they're recipients, or Medicaid recipients, or Medicare recipients, or just the ordinary citizen. The more the people are going to say, wait a minute, this isn't right. This isn't what we were told. So that's the other reason I think they're pushing to get everybody on board. So once you get on board, it's very hard to, get off. And that's the other concern I have if we were to expand, because they, I'd have less of a problem saying, we're going to look at for 3 years if we can get these reforms, some additional federal dollars, but plan for it to go away. That's fiscally responsible. But the problem is, one, I don't trust them, that the money's going to be there.
They
And
don't have
two,
the money.
Right, they don't have the money. And then three, we haven't been able to verify that these opt-out provisions that other states have put in their expansion plan has been agreed to. In other words, they're silent on that, which leads me to believe that they're going to come back and say, well, yeah, you had it in your plan, but sorry, you've expanded and we're not going to let you opt out. So.